Hello, everyone, and welcome to this discussion of COVID-19 vaccinations for prison populations and staff. My name is David Fati. I'm the chair of Penal Reform International, and I have the honor to serve as moderator for this important event. We meet at a challenging time. On the 1st of December, the Institute for Crime and Justice Policy Research at Birkbeck, University of London, reported that there may be as many as 11.5 million people incarcerated throughout the world, with incarceration rates in many regions increasing rapidly. At the same time, we are now nearly 2 years into the COVID-19 pandemic, which has taken the lives of more than 5 million people. There is no question that people who live and work in prisons and other places of detention have been hit particularly hard by COVID. In almost no other setting have we seen such rapid spread of the disease and such a high rate of sickness and death. In recognition of this risk, the World Health Organization, the Office of the UN High Commissioner for Human Rights, Penal Reform International, and Harm Reduction International, and others have called for exceptional measures to protect people living and working in prisons. And yet, despite this universally recognized risk, the response to COVID-19 in prisons has, in many places, been wholly inadequate, with incarcerated people largely left behind. Today, we will discuss one critically important aspect of the response to COVID-19 in prisons, the availability of vaccinations for those living and working in prisons. And to launch this report and give context to its findings, we are fortunate to have a distinguished panel of experts. I'd like to thank all of our panelists, as well as Harm Reduction International and Penal Reform International, and all of those who have contributed to this report and to making today's event a reality. A few housekeeping matters before we begin. First, this event is being recorded. We will have a number of speakers, and then we will have time reserved for questions and answers after our speakers have concluded. You're invited to put your questions in the Q&A box. If you look to the bottom of your screen a little bit to the right, you will see a box labeled Q&A, and you can type your questions there. You're also invited to contribute to the discussion in real time using the chat function, also at the bottom of your screen. Finally, if you are on social media, you can use the hashtag #PrisonVaccinations to tag your posts on this issue. With that, it's my pleasure to present our first speaker, Joel Hernandez Garcia from the Inter-American Commission on Human Rights, who will present some opening remarks.
Thank you. Thank you very much, David. Good morning, good afternoon to everybody. This is quite a distinction for the Inter-American Commission on Human Rights and for myself to be present at this very important event. I want to begin by congratulating Penal Reform International and Harm Reduction International for the report on COVID-19 vaccination for people in prisons that is launched today. Throughout the pandemic, as has already been said by David, several international organizations and non-governmental organizations have focused on the impact of COVID-19 in a prison population. We at the Inter-American Commission, we have also been following very closely the situation in prisons in Americas. As David pointed out, now the world is facing tragic amount of 5 million lives lost during the pandemic, out of which half of them, almost 2.5 million of people have died in the Americas. And this has been also a matter of concern, especially because our region, the Americas, has a high degree of people in prisons. About 60% of population in the Americas are in pretrial detention. And there are also reports on overpopulation. Sometimes we have found prisons in the Americas where the overpopulation goes as far as 300%, the amount of the size of a prison's capability. This has been very much a matter of concerns, and the Commission, as many others, raised their awareness when the pandemic spread, because we know that the prisons are a place where there could be lots of possibilities of infection. And in order to tackle that, the Inter-American Commission established a situation room to follow up the work of states and non-governmental organizations in dealing with the pandemic. We began by adopting one resolution, Resolution 1/2020 on a pandemic and human rights in the Americas, which established the basic human rights that should be present during this health crisis. We were aware that we were in the middle of a health crisis, but we didn't want that the health crisis to become a human rights crisis. And for that, it was important to establish the human rights standards that are applicable for this unusual situation. In that resolution 121, the Commission called upon states to reduce the number of people in prisons by means of resorting to alternative means of imprisonment, and also to take into consideration people who are in a higher risk of vulnerability in prisons, such as older persons, women, and mothers with children. Later this year, that Commission adopted Resolution 1/2021 on vaccines and human rights obligations. We are now facing in many countries the fourth wave, and it has proved now that vaccines are very important. And the Commission has focused its attention now in vaccination plans throughout the Americas, because we know that the best scientific evidence shows the usefulness of the vaccines in order to spread the disease. And for that, it's very important that states focus their attention on people deprived from liberty, as they are one of the most vulnerable groups. In Resolution 1/2021, the Commission made 3 very specific recommendations. The first one, states should ensure that distribution of vaccines and their equitable and universal access should be done through the development of a national vaccination plan. Second, with respect to groups in situation of vulnerability or groups which have been historically discriminated, states should adopt public policies to respond to differentiated, intersectional, and intercultural approaches for vaccination plans. And third, the Commission called upon states to address the particular needs deriving from several factors of discrimination, as it could be age, migratory status, gender identity, disabilities, ethnicity, race, and very important, the context of deprivation of liberty. With this, the report on global scan that now is presented to us, it's a very welcome exercise, because this allows the Commission to have a very well-founded reference in order to determine progress made in achieving vaccination in prisons, not only to people deprived of liberty, but also to prison staff. And on that basis, the Commission would be able to have a point of reference in order to continue monitoring the situation of prisons in the continent, and more importantly, to exhort states to continue and strengthen their national vaccination policies with special attention to people deprived of liberty. So I conclude by thanking Penal Reform and Harm Reduction International for this report. And again, I'm very honored to be part of this of the launch of this of this important report. I thank you.
Thank you, Joel, for those opening remarks. Thank you also for reminding us of all the reasons why people in prisons, people deprived of their liberty, are particularly at risk from this pandemic, and of some of the factors like overcrowding that exacerbate that risk still further. We are certainly very grateful for everything the Inter-American Commission has done in response to COVID, and all the work the Commission has done over many years and decades to ensure humane conditions for people deprived of their liberty. Next, we will hear key findings of the global scan. And for that, we have Giada Girelli, human rights analyst with Harm Reduction International, and Trina Lenehan, policy and international advocacy manager from Penal Reform International.
Thank you, David, and thank you everyone for being here today. I was going to share some slides. I don't think I'm able yet, but just while we fix this sort of technical glitch, I'll just give you, I'll present some of the content and rationale for the report, but I just want to say a couple words on why this issue of vaccination in prison is a drug policy issue. As you know, Harm Reduction International works on health and right-centered drug policies. So I hope you can all see my screen now. Great. So why is this a drug policy issue? There are two main reasons for that. The first one is that people who use drugs are overrepresented among prison populations worldwide. We know from estimates that around 1/3 of people in prison have a history of drug use. And we also know that between 56 and 90% of all people who inject drugs will be incarcerated at some point in their life. And so if we care about the rights and health of people who use drugs, we cannot but pay very close attention to what happens within prison walls. This is particularly important when it comes to health issues. Also because of stigma and marginalization, people who use drugs are more likely to have pre-existing health conditions than the general population. And this means that they're more likely to contract COVID, and if they do contract COVID, to suffer important consequences from it. The second reason is that punitive drug control is a key contributor to poor conditions of detention, and to these very conditions, some of whom were presented in the opening remarks, that fuel the spread of COVID-19 in detention settings. More than 1 in 5 people in prison today, and more than 1 in 3 women in prison today are detained for a drug offense, often minor possession-related offenses. And so punitive drug policies are a key driver of prison overcrowding around the world. And unfortunately, in some countries, these figures are even worse. For the fact that drug policies also are predominantly punitive around the world means that most attention is paid to criminal justice responses while sidelining public health responses. And as a consequence, essential harm reduction services are very limited or absent in prison. This makes it more, this heightens the risk of people contracting HIV or other health conditions while in detention, in turn exposing them to COVID-19 and other diseases. And finally, the fact that drug policies are so ingrained meant that even during the pandemic, drug arrests and rearrests continued. In fact, in some contexts, we saw them increasing. Also because in context of lockdown, people engaging in the drug market become more visible to law enforcement. And so punitive drug policies contributed to the failure to decongest prisons during the pandemic. Now, moving to the report. Why do we think people in prison, both living and working in prison, should be prioritized for vaccination? And first of all, there are health-based considerations. Some of them I already touched upon a second ago. The first are the typical features of the prison environment. Many prisons, unfortunately, are structurally overcrowded, and all attempts to decongest prisons have, a lot of attempts have failed. In 2020, HRI published a global scan of COVID policies to release people, so the early release and decongestion policies related to COVID-19. And while we found that these policies were adopted in the majority of the countries around the world, we also saw that because of issues with their design and implementation, decongestion essentially failed at the global level, although there were some positive practices. Less than 6% of the prison population was released pursuant to these measures. And as a result, people in prison remain in an environment where it's just impossible to physically distance and to implement COVID safeguards. And so vaccination becomes a key tool of prevention and protection. As I was mentioning before, people in prison also experience higher rates of health vulnerabilities, including communicable health conditions such as HIV and TB, as well as accelerated aging. And so they are more vulnerable to COVID-19. And finally, health services in prisons are often more limited availability, accessibility, and quality than in the broader community, meaning they're less able to respond to COVID-19 successfully. As PRI noted in the global prison trends, the situation has essentially become worse in many prisons since the COVID-19 pandemic started, which means that a lot of prison services simply were not equipped to deal with COVID-19 successfully. And so again, vaccination becomes a key tool for prevention and protection. These issues I was talking about are reflected in the data of COVID-19 in prison. Justice Project Pakistan reported almost 600,000 cases of COVID-19 in prisons worldwide. And we saw that in a lot of countries, prisons essentially became COVID-19 clusters. This has a direct impact not only on people detained and people living in prisons, but also in the broader community. As we know, prison health is community health. And so prioritizing the prison population for vaccination is not only humane and the right thing to do, but it's also strategic from a public health standpoint. Now, quickly, there are also human rights considerations. As we know, human rights standards are clear that people in detention retain their human rights to health, and they have the right to at least the same standard of care as people in the broader community. With regards to COVID-19 vaccination specifically, standards were developed by a bunch of authorities, including the WHO, the Inter-American Commission of Human Rights, as it was mentioned, and the UN Subcommittee on the Prevention of Torture, which in 2021 recommended states to include in the national vaccination programs with priority all persons deprived of liberty and all personnel of places of deprivation of liberty. And so, again, not only health considerations, but also human rights considerations. Moving to the methodology, the research was led by HRI and PRI with support from a lot of local and regional organizations who helped us collect information. We looked into 177 countries and we looked into policy and practice. We basically only left out countries with a minimal prison population or on which absolutely no information was available. We collected information until October 2021, so most figures are updated as of September 2021. Of course, the practice will have changed slightly now, but the findings paint a very clear picture of the trends with regards to state approaches to and consideration of detention settings in their planning, in their thinking around vaccination, and give some best practices and key challenges to vaccination. With regards to sources, we used, where available, official figures and official policy documents. Unfortunately, I have to make a note already that a lot of these documents simply were not available or publicly accessible. We also looked into independent reports by civil society organizations, by the UN, by media, by network of prisons administrations. We sent requests for information to UN agencies involved in the vaccination at the national level and to state officials, both at the health and the prison and on the prison side. Unfortunately, a lot of these letters went unanswered. And finally, as I was saying before, we got very valuable input by local NGOs, especially in Southeast Asia, South Asia, and the Middle East, who monitored the situation and contacted authorities at the local level. Finally, and then I'll let Rina talk about the other findings. I have a point on methodology, which, however, is also a key finding of the research, meaning the dire lack of transparency and availability of information on this phenomenon. As I was saying before, we simply couldn't find official policies for a lot of countries. We ended up finding some kind of official documentation for 131 countries. Often they are not full documents, which also made it very hard to conclude which categories were included and how. Also a point that to prevent other people from going through the same obstacles, we collected all the national vaccination plans we could find and put them in a folder available for everyone on the Justice Project Pakistan page. In these documents, often certain vulnerable groups are mentioned and prioritized, but it was also unclear whether these groups meant to include people in detention. In a lot of cases, simply there was a failure to mention prisons or detention settings at all, which I think says a lot about the lack of specific targeted attention to this category. And finally, we had even more issues finding figures, numbers of all the 177 countries. We only found 6, which provide a publicly available, accessible, updated, and somewhat disaggregated database that people can look into with COVID-19 vaccination figures with regards to prisons. For 79 countries, we could only find incomplete and not updated information. For other 92 countries, we simply couldn't give any figures. And data collection was particularly hard for prison staff, although they are key components of the prison community and also of the community, the broader community, and so they deserve thoughtful consideration. The scarcity of information is also related to the fact that different prison staff fall under different categories, different professional categories, and also the fact that prison staff is often vaccinated in the community. However, let's say that for at least, if not over 40% of countries, we couldn't even definitely conclude that this population was targeted in a systemic way for vaccination, which of course is a problem. So again, this is a methodological point and it's something that should be taken into account when reading the report. But I'd like to stress this is not only about methodology, this is also and primarily a violation of the right to health, as well as of the right to participate in public affairs, particularly for affected communities. It's a lack of information that hinders accountability for failures of the state. It prevents evidence-based decision-making and says a lot, I think, again, about how prisons were or were not on the radar of many policymakers when developing and implementing vaccination plans and rollouts. I stop here. I'll let Trina go through the other findings, but I'm happy to answer any questions in the Q&A. Thanks.
Thanks, Jada. Yeah, unfortunately, the issues around data collection and transparency are quite a theme throughout the report. So as Jada mentioned, I'll take you through some of the key findings. Firstly, on how prison populations and staff have been included or prioritized in national vaccination plans. So overall, with some exceptions and variations, we identified 4 broad approaches to prisons in national vaccination plans. First, we have those which specifically include prison populations or staff as a high priority for vaccination. And those are represented in purple on this graph. So you see there are sort of more for prison staff, just over half of those where we could identify plans, as opposed to the prison population. But this is also where the fragmented inclusion of prison staff comes in, because in 15 of these countries, we could only confirm some staff as high priority. So that can be example if they're above a certain age or if they're members of security forces and so on. In orange are those countries which explicitly mention the prison population, but assign them a lower priority or even amongst the last groups for vaccination. So this was not very common for the prison population, and we didn't identify any of this category for prison staff. In blue are those which Jada referred to earlier as well, where it's unclear because they mention groups that prison populations or staff could reasonably be understood to fall within. So like those that are living or working in closed settings or who cannot physically distance, but it's not clear because it's not explicit if they are actually considered as such or included as such. So this is much more common for prison staff. who are often could be included as essential workers or under law enforcement and so on. And in grey then are the national plans that do not mention prisons at all, so either directly or indirectly. And this is by far the most common approach for prison populations, unfortunately. We can see the difference in approach between the prison populations and staff when we look at the degree of prioritization that's given to each group in national vaccination plans, which explicitly mention them. So as you can see, there are 20 countries, which is almost a third, which include prison staff in the highest priority for vaccination, compared to 8 countries, or about 16% for the prison population. People in prison were also more likely to fall into low priority categories, which was the case in about 67% of countries where they are mentioned in the plans, compared to 38% of those that mention prison staff in low priority groups. At the national level then, when it comes to actually administering the vaccines in prisons, we saw different approaches to how authorities rolled out COVID vaccines within and between prisons. So in many cases, it seems that within the prison population, people are prioritized based on vulnerability to the virus. Factors like age, sorry, I've gone on the slide. Here we go. Factors like age and pre-existing conditions. And this approach is most in line with the principle of equitable distribution, but it's probably logistically more complex because it will mean vaccinating different groups in different prisons at different stages. So it may depend on who is administering vaccines in prisons and whether that's the existing health staff, or in some places, mobile vaccination units were used, which traveled around prison by prison, following some other criteria. So for example, in Denmark, we saw the order of prisons was based on the average age of the facility. And so the mobile units started with those with the highest age composition and continued in that way. So we also saw numerous cases where plans or their implementation used mixed approaches. So this could be, for example, if the prison population is included as a low priority group, but in fact, particularly vulnerable people in prison are being vaccinated in earlier stages, or maybe specific prisons are prioritized earlier. And that often was in response to outbreaks, either in a prison or in a geographical area. And also some cases where certain groups are prioritized or excluded on political or other grounds which are not related to health needs. So turning then to how these policies are being implemented in practice, in other words, how many people detained and working in prisons have been vaccinated as of September this year when the research was completed. So 2 key points to remember here. First is the extreme inequality in vaccine distribution between countries, which does not in itself justify excluding people in prison, given all of the intersectional vulnerabilities that we've discussed already, but also really significant differences between countries in their vaccination plans, the availability of vaccines, the size and characteristics of their prison populations, and a whole range of very practical or logistical kind of vaccine challenges. And we'll hear more about the different contexts from some of the other panelists today. So this map relates to prison populations. The purple countries are those where vaccination of the prison population has started, and at least 80% of the prison population had received at least 1 dose of the vaccine as of September. So there are 20 countries where this is the case. And in blue are where vaccination has started, but less than 10% of the prison population had received at least 1 dose. And that's 29 countries in total. But also bearing in mind, as Jada mentioned, these are, where we could confirm the information. So these are really the minimum confirmed numbers. In fact, possibly more have achieved higher rates, but if the data isn't published or it wasn't accessible. In orange then are those where vaccination has started, but progress is unclear. And the darker gray is where vaccination had not started, and the light gray is where it's completely unclear if vaccination had started or not. So when we compare this progress when we compare that to progress on vaccine rollout among prison staff, you can see the number of countries where it's unclear if vaccination of prison staff has started yet is much greater. And this comes back to the point Jada made earlier about the lack of data collection in relation to staff. But we could confirm at least 7 countries that had vaccinated all prison staff who chose to. And in addition to the figures, then, the report explores a number of issues that have emerged in relation to COVID-19 vaccination in prisons. The first is around free and informed consent, which is a clear requirement under human rights law, medical ethics, and particularly the Nelson Mandela rules. So in many countries, it's clearly stated that vaccination is voluntary, and that's reflected in the uptake, with some percentage of the prison population deciding not to receive the vaccine. But in some countries, it's unclear whether vaccination is voluntary, if it's heavily incentivized, or if it's mandatory, and also what the consequences for refusing the vaccine might be. And we're starting to see this discussed a lot more now, particularly in relation to prison staff. And linked to that then is around vaccine hesitancy, which has really varied significantly across countries. We saw about 50% hesitancy rates among prison populations in some countries, and different factors feeding into that depending on the context and the specifics. Both of those issues then really raise the question around the availability of accessible, targeted and evidence-based information on COVID-19 vaccines for people in prison to allow them to make informed decisions about their health. So we've seen the benefits in some places of education campaigns, particularly peer-led information campaigns, and also the possible impact of which vaccines are offered in prisons and whether that influences people's choices. Finally, the report sets out a range of recommendations to improve access to vaccination in prisons and protect the right to health generally. There are 13 in total, but so I won't go through them all individually, you'll be glad to hear, but they're grouped into 3 broad themes. So the first is around the explicit inclusion and prioritization of people detained and working in prisons in all COVID response plans, including national vaccination plans. And within that, prioritized based on individual risk to COVID-19, that all vaccinations should be based on free and informed consent, and to facilitate that, the availability of targeted and accessible information. In relation to transparency and accountability, authorities should regularly collect and publish data on COVID vaccinations of prison populations and staff, which is disaggregated by age, sex, and so on. And the same for the number of infections, deaths in prisons, and other health factors. And for all COVID-19 responses to be reviewed with really meaningful participation of civil society and the affected communities to inform the policy and pandemic response now and in the future. And lastly, then I'll finish up because I know I've reached my time. I can see David checking the clock. Finally, there are 5 recommendations that more broadly promote a health and human rights centered approach. And I know some of the other panelists will speak to the impact of some of these recommendations, so I'll leave it there and look forward to hearing from the other speakers.
Thank you, Jada. Thank you, Trina. So many important points in your presentation. The way in which punitive drug policies have exacerbated the effects of the pandemic, both within prisons and in the broader society. The global failure to depopulate prisons in response to COVID, which I think is one of the greatest public health failures and missed opportunities of this century. The reminder, always appropriate, that prison health is public health, that the virus doesn't respect the prison walls, and that if it's in the prisons today, it will be in the community tomorrow. And finally, the fascinating findings of this groundbreaking study, I think one of the most significant findings is just the lack of information and the lack of transparency, which, as you pointed out, speaks volumes about the importance and the priority accorded to prisons and the people who live there and work there in many societies. The World Health Organization's Health in Prisons program has played a vital role in providing guidance and support for health responses in prisons. And earlier this year, issued an advocacy brief calling for the inclusion of people detained and working in prisons in COVID-19 national vaccination plans. Our next speaker is Filipa Alves da Costa, public health specialist for the World Health Organization, Regional Office for Europe's Health in Prisons Program, and she will inform us on some of these developments.
Thank you. Thank you very much. I suppose you can see my slides now. Yes, not in full mode. Yes, so thank you very much for the invitation to come and speak to you about this advocacy brief, which indeed we have launched in early May this year. Much of what I'm going to present has been referred during the previous presentations, but it's of course a different approach. So this is not so much about the data that there is, but more about the recommendations that we issue. So we have published this brief, which was developed in collaboration with Penal Reform International and also with UNODC, which was calling for the inclusion of people living and working in prisons in national vaccination plans. So I stress the inclusion, not the prioritization, but this was indeed what was being argued for. The reason why we developed this brief was because we were being contacted by some countries saying that they could not convince their governments to include prisons in national vaccination plans. So this was what led us to develop this work. And we tried to answer mainly these two questions. What are the key considerations for including people in prison in national vaccination plans, and what are the underlying principles guiding these considerations? I believe you will have the slides available to our participants, so you have the link to the brief itself in the slide. So what we have done was a rapid literature review at WHO, and then we had some input from external stakeholders. We then issued a call to member states in the European region, because that's where our office operates. But we also achieved contributions from other member states beyond Europe with the collaboration, as I mentioned, of PRI and UNODC. Then finally, we had input from internal divisions to ensure that the guidance issued was consistent with WHO policy. So I'll take you through these recommendations. These are the considerations. We have 6 considerations. And the first one is to include prison populations because mainly they are unable to take the public health and social measures that are needed to prevent the infection. And these, of course, include vast measures, but we highlight the physical distancing aspect and, of course, the ability to have hand hygiene. So this applies, of course, water and soap, but also hand washing facilities. Of course, most arguments that we present in this section are about the inability to physically distance. And this calls for the recommendation that was also issued in the brief that was just launched by PRI, the consideration to address overcrowding. So the second consideration is to include older people that are living in prison. And in here we stress what's also mentioned in the PRI brief, that it is important to consider the aging effect of prison itself. So we cannot set as cutoff value the 65 as age group considered old, because in fact, if we were to do that in prison, we would miss some of the elders that are there. Another aspect that we highlight is the inclusion of people with underlying health conditions. And of course, communicable diseases are extremely important, but in most cases, there is above all scarce information about the prevalence of NCDs in prisons. And these we know will contribute to severe outcomes of COVID-19. The fourth consideration is the inclusion of prison staff and, of course, healthcare staff as essential health and care workers. And it's important to note that when we produced this brief, we had some information above all from the first wave of the pandemic that was suggesting that up to 85% of all cases were coming from prison staff. So this, of course, means that we should protect them above. Then the final consideration, the fifth consideration and the sixth one is to include people in prison because of the risk of transmission into the community. So some people tend to think that prisons are isolated from communities, but of course they're not. We have people coming in and out every day. And this means that we have the duty to protect also the communities from the effect that an outbreak in prison will have on these communities. And also another aspect is the fact that many people that are living in prison come from marginalized groups of society. So of course they have limited access to healthcare. Then I pass on to the principles, also previously referred to. So we stressed 4 principles. One of them is the fact that when people are deprived of liberty, governments become accountable and they have the duty to ensure all people deprived of liberty have access to health and to healthcare. The second one is equity. Of course, every citizen has the right to health, but this is regardless of their legal status, and this is well established in WHO definition of health. The third one is universal health coverage. This is in fact one of the objectives of the current European Plan of Work, and it clearly mentions that no one can be left behind, and this of course includes all of those living in prison. The fourth one is continuity of care, and here we call for the need to ensure that people that are receiving the first dose in prison and then get released, or vice versa, they get the first dose in the community and then get arrested, then there should be mechanisms in place to ensure that people do not miss on the second or eventually on the booster dose. So we need a coordinated response to ensure that resources are not wasted. So the key messages that we have in this brief are 4. So to include people in prison in national COVID-19 vaccination plans on the basis of their increased vulnerability, the principle of equivalence, and the duty of governments to protect those that are deprived of liberty. The second one, which is also very clearly presented in PRI's brief, is to make sure that people are informed how to protect themselves from COVID-19 by immunization and other public health and social measures. And this, of course, implies giving them all information, but also allowing them to choose if they want or not to be vaccinated. Then, of course, we recommend that the facility-wide vaccination approach is followed, but whenever this is not possible, then we recommend that vulnerable groups in detention are prioritized. And finally, we recommend the prison workforce, and this includes healthcare workers, but also prison staff, that they should be prioritized for vaccination as healthcare workers at high risk. So just to finalize and to present you, because there was lots of arguments about the scarcity of data, which we obviously agree with. So as a response to this brief, we have continually tried to collect updated information from voluntary submissions by member states on the vaccination status. And we issued this brief in May 2021. This can, of course, be a coincidence, but we hope it had some influence in seeing what we see in this slide, that it is very clear. I mean, different rhythms surely exist across Europe, but it is clear that there's a progressive uptake of vaccination in prisons. And then on this slide, we can also see the most recent updates where we have, and what's visible here and what I want to stress is that in certain countries, we have enough information on the provision of the first and the second dose, whereas in others, we only have information on the first dose. And this is, of course, extremely important because it was mentioned that there was not enough data available and often not updated or disaggregated. But I think it's also important to add the quality of information. So in certain sources, we have cumulative doses, and this, of course, does not allow us to estimate vaccination coverage. Of course, there are many countries that do not provide us information, but as it was also stressed, these are the countries where normally there is quite an important vaccination hesitancy, and this is clearly related to the outcomes of COVID-19. So what I show you in this slide is that in red, you see the countries where we have a higher rate of infection in prisons compared to the communities. These are profile 1, where you have very low vaccination coverage. These are the ones where the attack rate is similar, and these are the ones where you have prisons kind of safer than in the community. And here the vaccination coverage is much higher. So thank you very much for your attention. And I believe I was just 1 minute extra time. Sorry for that.
No apologies necessary. Thank you so much for that very informative presentation. And we are all very grateful for the indispensable role that the World Health Organization has played and continues to play in ensuring that people who live and work in prisons are included in national vaccination plans. Dr. Raed Abu-Rabi is health coordinator at the International Committee of the Red Cross. He has been working for ICRC for 27 years in various positions. He was also in charge of the Health in Detention Unit at ICRC's headquarters in Geneva. He has been involved in studies, guidelines, and training related to healthcare in detention worldwide.
Thank you, David. First of all, thank you for inviting me, and I would like to thank Prison Reform International and also Harm Reductions. I think the report provoked a lot of discussions, which is extremely important for such circumstances. That's the first thing. Second, I will talk only about vaccination in prison, not places of detention, because there's a lot of differences. So I'm talking only about prisons, and I will go a little bit more deeper into conflict or area where access is difficult for other organizations to come in. But I will start with the positive point through the progress which I have seen related COVID-19 in the places of detention. In many countries, I have seen that they start to put infection and prevention control in the places of detention, which was something which we try for TB many times, but sometimes it was difficult. But as this is a crisis, I think they did a kind of an effort, even if they have a lot of overcrowding in many countries. They give some space, they start to do testing. Also, there is a lot of materials coming from donation about prevention, or let's say a kind of hygiene items. Just also vaccination has started in many different conflict areas. Maybe it takes some time, but actually because, not necessarily because they didn't want to do it, but because they didn't have the mean and nobody donate for them this vaccination. So once they receive it, definitely the civil population outside took the benefits, and then after that the detained. But still, I think the advocacy which has been done by different organizations led them into having some vaccines inside the place of detention. Also, this epidemic has forced the Minister of Interior, Minister of Justice, and to talk to the Minister of Health, because actually they have they are not able to do it by themselves. So they were obliged to go to the Minister of Health and to talk to him about these epidemics, which is a good point somehow, but also it's a bad point. I will talk about it later. But this is something which we have seen, that the Minister of Health was part of the discussion about health of the detainees, and he didn't know. So he was asking ICRC or other organizations to say, okay, can you help us? Second thing, there is a written recommendation, and thanks to WHO, not only on Europe, but somewhere else, the guidelines has been taken, and at every place nearly there is a written recommendation which need to be followed. So this is a very good point, which is not the case in before. Last but not least, budget was allocated to the places of detention, which is not in many cases has been budgeted. So there is a small budget which has been given to the places of detention, which has extra for the prisons. That's include hygiene item, that's include vaccine, that's include more stuff in some country, which is a very good point. Then I come for the challenges which we face in these countries. Actually, in countries of conflict, it's not like in Europe somewhere else. I'll give two practical examples. The first one, Afghanistan, where they release all the detainees, but they keep a lot of intravenous drug users. These people has no food yet. So when we come to talk about vaccination, the priority is food than only vaccination. So the priority completely changed. Ethiopia, in various countries and places in the country where access to the prison is limited. They have no drugs, not even a nurse, not even medical, not even. So finally, you come for the COVID, but then you have to take in consideration it could be something after the food and access to basic health care. And it's always a discussion, because actually the people, they want the vaccination. Wait, they need to eat first before we talk about vaccinations. And sometimes this is a state of mind and discussions. What is interesting, at least from my experience in the last 3 months, I have seen many countries has restricted movement to go into the prison. And they took the COVID-19 as an excuse not to let the people come in, and international organizations, meaning because of COVID, you cannot come to visit. And actually, we are coming with material, we are coming with knowledge, we are coming with support, but it was taking an excuse, not let the other organization coming in, which actually it is the moment to letting them come in, but it was taken as an excuse. I think I saw in one of the remarks is that the family visits, if you stop it, if you stop family visit and you stop the other organization coming in, the detainees will be in a big difficulties because the food are coming from the family. And so we start to have very in some places of detention because the family is not bringing food with multiple vitamins and etc. So it was a constraint by itself. Something which I have also noticed is that in some countries where the Minister of Health is in charge of the health of the detainees, the impact is very quick. I give concrete example. Sri Lanka. They vaccinate all the detainees in Sri Lanka because the Minister of Health is in charge. He did in-point, out-point. It means all testings, everybody has to be tested in and out, everything needs to be done. Second example, Jordan. What we did together is that to have transitional area, anybody has been judged by the court or arrested, he cannot come into the prison until he will have testing and staying 14 days before joining the big team of prison services. This is a very good practice, which is somehow indicate the difficulties when the Minister of Interior and Minister of Justice not. And we really have a difficulty sometimes to discuss with the medical matters because it is over their tasks. Varieties of vaccines. It was very interesting for me. Vaccines were coming donation to conflict area. So finally, if you have Pfizer for the first wave, the second wave could be Moderna, or it could be Chinese, or it could be Russian, or it could be, and they were a confusion. Can we give them multiple one? Can we give them one? So we will depend on the vaccine, which is coming donations, not really structured and organized. And we can vaccinate half of the detainees and not necessarily the others because simply we don't have. Is there an effort? Yes, but is it organized? Not necessary. Everybody talk about reliable data. We collect data, but definitely in COVID-19, in conflicts, and areas, the data was a lot of confusing because they were mixing a lot of things, some not necessarily with tests, some of them not vaccinated really, some of them they take one. So it was very complex. And we have to be very careful when we talk about really reliable data. Something which is also indicate for me was the mortality rate. We tried to see if the mortality rate has increased in the place of detention, and definitely it has increased. And we were giving some ideas what it could be increased, but one of them definitely was the COVID inside the place of detention. But the second one was there were no transfer from inside the prison to outside, because simply restriction of sending to the hospital, which is full of COVID-19, and the authority has no means even to respond to it. And now you bring him some people from the prison, it's really, really difficult for them to be able to cope with, which was really an issue to decrease the mortality rates inside the place of detention. Now, if you compare between the mortality rate in the places of detention and mortality rate outside the place of detention in the period of COVID, for COVID-19, we discovered in some areas in the prison, it was less than outside the prison. But is it can make it for all the countries? It's very difficult. You have to take it according each country by each cell. Last but not least, which is a very, very important question. I have noticed that if you want to be vaccinated in some conflict area, you are obliged. Nobody asks you. So it's forced vaccinations. It means you have to take it, point. There is no medical ethics related, there is no discussions why you don't want to take it. And I always appreciate the people who talk about staff in some conflict area or even some Asian country, some of the staff, guardian or etc., they have committed suicide. Why? Simply because they couldn't cope with all the pressure they have about not seeing their families. They have to stay inside the prison, but they cannot be in touch with the detainees. So it's a complex issue when it comes to the staff, and more attention needs to be given for that because they are the ones who are living for it. So it's not only the detainees who are not allowed to go outside or to go to health structures, but even the national people from the prison guards or prison authority, they were not always allowed to go to see their family to avoid this transmission of the COVID-19. I don't think that we will be able to do it until to have something like these discussions, to have promotion of report like Prison Reform International, harm reduction, even ICRC, to push that this has to be equal to everybody, but respecting the ethics which has been discussed by the World Health Organization just now about Europe, because it will not change for any countries in conflict or not conflict. I stop for here, and thank you very much.
Thank you very much for that very informative report that covered some positive changes that may come out of this otherwise very horrific situation. And also the many, many challenges that remain, including the fact that COVID has restricted access to the prisons, not only for family members, but for oversight bodies, and therefore has further reduced oversight and transparency and accountability in prisons. Since the beginning of the pandemic, Justice Project Pakistan has monitored cases and deaths as a result of COVID-19 in prisons globally with a live interactive map on their website. And today they launch another interactive map representing the data in the joint report being published today. JPP has also conducted a range of advocacy activities at a national level to promote protection from COVID-19 in places of detention, including vaccination. And we are very pleased to welcome Zainab Mahboob, head of legal for Justice Project Pakistan, to tell us more about this work.
Good evening, everyone. Thank you so much for inviting me to be a part of this panel, and thank you for the introduction, David. So I will just start by telling you that as a part of our work, we regularly visit prisons to meet our clients. And when pandemic hit in 2020, we faced a lot of difficulties in meeting with them. Initially, prison authorities had no idea how to deal with this situation or how badly this will affect the prison population and prison staff. So at that point, we decided to develop an interactive map and monitor how COVID is affecting other countries and what steps these countries are taking to contain the pandemic. In Pakistan, one of the primary reasons of prisons being affected badly was overcrowding. Pakistan's prison overcrowding represents a high risk for any situation of outbreaks of communicable diseases. Lowering the number of people in detention facilities is therefore a key way to lower the risk of irreversible health consequences or death of people in prison, including prison staff. Pakistan's overcrowded prisons hold one of the most vulnerable body of prisoners with inadequate health and hygiene facilities, leaving them exposed to a contagious and deadly pandemic. As a result of the overcrowding in some prisons, between 6 and 15 prisoners may occupy a single jail cell built to hold a maximum of 3 individuals. There are currently approximately 80,000 prisoners in Pakistani prisons against authorized capacity of 57,742 prisoners. This is 34% more than the official capacity. With these conditions, it was near to impossible to maintain social distancing. So to curb this situation, the initial response of the authorities was to shift prisoners between different prisons. Usually our central prisons are more overcrowded. So in the beginning, prisoners were shifted from central prisons to district prisons to make sure that they are equally settled in different prisons. So we met prison authorities of all the provinces, and we assisted them by giving recommendations about how to reduce the prison population and provide better health services to the prisoners. They stopped sending, another initial response was that they stopped sending the prisons to the court for hearings on everyday basis. Approximately, if there are 1,000 prisoners in one prison on daily basis, 500 prisoners come and go from prison for the court hearings. And they were at high risk of bringing in COVID when they came back from their hearings. So they tried to stop the hearings for about 2-3 months, but that was an initial burden on the justice system, and that increased the caseload in the following months. So in March 2020, the Islamabad High Court recognized that the critical need to reduce the rampant overcrowding in the jail to combat the spread of the virus, and ordered the release of several categories of prisoners in view of the vulnerabilities of the virus and to reduce overcrowding. The following month, in April 2020, Supreme Court passed an order identifying vulnerable prisoners competent for early release, and in September 2020, approximately 6-7 months later, the directions were also issued by the Prime Minister of Pakistan to release the prisoners. So the categories they identified were prisoners suffering from physical or mental illness, under trial prisoners who are about 50 or older, male under trial prisoners, female and juvenile under trial prisoners, convicts who have completed their sentences but remain in jail on account of non-payment of fine or monetary penalty, women and juvenile convicts who have completed 75% of their sentences, convicts who remain term in jail is 6 months or less, and women and juveniles who were sentenced to a term of 1 year or less. But it has been approximately 19 months since the Apex Court's order authorizing the early release of vulnerable prisoners, and 14 months since the Prime Minister's directive reaffirming the Supreme Court's direction. And nevertheless, it remains unclear what steps have been taken by the provincial government to give effect to these orders. And moreover, it is unknown how many prisoners have been released under these directions. So initially, there were a lot of problems faced by the prisoners, and because of the prison conditions, that no special measures taken for vulnerable prisoners, including mentally ill, prisoners with pre-existing conditions, and elder prisoners. Visits of doctors from adjacent public hospitals were also suspended, making it hard for the prisoners to obtain medical assistance. In March 2020, at the start of the COVID-19 outbreak, prison authorities banned all visits to prevent transmissions, but this created more problems for the prisoners, as a lot of them rely on their family for medicines, food, and wait an entire week for a meeting with their families for emotional support. So to reduce this gap, the prison officials installed PCOs in jails where prisoners were allowed to call their families once a week, and authorities allowed the families to drop off the stuff for their prisoners, which was then given to them after being sanitized. But finally, a few months later, families were allowed to meet the prisoner once every 15 days. And even, we are about 18 months into the pandemic, but lawyers are still not allowed regularly to go and meet their clients. Prison staff also faced a lot of challenges, that there were lack of resources and facilities for them, such as sanitizers, masks, no PE kits were given to them. Initially, they had to rely on donations in the earlier days of the pandemic for masks and sanitizers. And when those donations ended, there was no supply of these things for the prison staff. Additionally, additional COVID responsibilities assigned without, deploying, deputing, or recruiting new staff to handle extra workload. This actually affected their physical and psychological health as well. Prison staff and prison population were not part of the national vaccine plan in Pakistan. And till late March, they were not even considered as people who should be vaccinated. So Sindh was one of the provinces who took the lead, and in late March, they started vaccinating the prisoners and the prison officials both at the same time. But however, initially they were prioritized based on their age, health conditions, and amongst them as well, only there were those who were vaccinated who had their national identity cards, because the vaccination system was attached somehow with our national database. So only those people could get vaccinated who have an ID card. And if they don't have an ID card, they were not allowed to get vaccinated. So this was an additional problem. As the whole system was linked to the national database, so this was prerequisite, but soon they realized that not enough people have identity cards in prisons. So they had to end this condition like a few months later, about, I guess in September, October, they realized this. And then they started vaccinating all the prison officials and the prison staff, the prisoners. But it had to be age-wise. Initially, they started with prisoners and prison officials who were 60 and above, and then 50, and then 40, and then 30. But nowadays, it's open for everyone. So vaccinating the prison population and staff has been a slow process. Initially, the vaccine given to the prison population and the staff was a single dose, and it was easier to administer and did not require multiple visits of the health officials to the jail. From the beginning till now, it has been a responsibility of the health department to visit the jails and vaccinate prison population and the staff. For the last few months, they have been giving vaccinations that require 2 doses, and this has further slowed down the process. We noticed that prison staff was initially very hesitant in getting vaccinations, but then government made it mandatory for them to get vaccinated, otherwise they'll not get paid. So all of them had to get vaccinated, or at least first dose, before the 30th of June. Otherwise, the government announced that they will not get salaries. And the last problem that we faced in gathering the data about the vaccination and when we were making a COVID tracker initially was that there is a lot of problem in transparency. There is no transparency. There are no official figures given by the government, and we just have to make contacts, go to our contacts, ask them for all the information. So the only province that was a little open and transparent in giving the details and figures was Sindh government, but others unnecessarily just kept on hiding the details. And lastly, so far, according to the data we were able to gather, at least 13,851 prisoners have received first dose of some sort of vaccine in Pakistan prisons. Yes, thank you so much.
Thank you for that fascinating case study of the situation in Pakistan, both of the problems faced by those who live and work in prisons, and of the very concrete solutions that JPP was able to promote. I have to say that so many of the problems you describe in Pakistan sound familiar to me based on my own work in the United States, and I'm sure many others who are listening today have that same experience. We have a special guest, a last-minute addition to the agenda. Dr. Emma Pluggy from RiseBack will now join us for a few minutes. Emma, are you with us?
Hi, I'm so sorry.
Oh, there you go.
I'm having some technical difficulties at the moment. Can you hear me? Or you might be able to even see me now. Anyway, thank you so much, and I'm very grateful for you giving me space this afternoon to talk about very, very briefly, I understand, about the RISE-VAC project, and I will be sticking some details in the chat about the project. But just to say very briefly, I'm speaking on behalf of the RISE-VAC consortium. Essentially, it's a consortium of 6 countries across Europe. That's Moldova, Cyprus, Italy, Germany, France, and the UK. The project is led by Italy, the University of Pisa. There are 9 partners with a variety. Some are governmental, some are non-governmental, and a lot of academic institutions. It's an EU-funded project. And what RISE-VAC stands for is essentially reaching the hard to reach, increasing access and vaccine uptake among prison population in Europe. And so I wanted to flag up this project that's going on. 2 key goals. Firstly, to develop individual-centered and evidence-based models of care to increase vaccine literacy, access and vaccine uptake among prison populations, and also to support decision makers, experts, citizens to value and foster quality prison healthcare in order to tackle health inequalities and health gaps in the European population at large. And obviously it is very European focused, but we're hoping that to learn from other countries and hoping that some of our learnings will be relevant to other countries as well. So essentially it started on the 1st of May 2021. So it's still early days yet. It's a 3-year project, and we should be coming up with some more findings in the coming year, but I will put on the chat just some links to the project, and if anybody is interested in following our progress and our emerging findings, and some of our key outputs are going to be resources, not just for policymakers, but also practitioners, for staff, for people, imprisoned people, so that we can work towards this goal of increased vaccination, not just COVID vaccination, but actually all vaccine preventable diseases. Okay, I think that's all I needed to say, just to highlight that, but happy to take questions. Thank you.
Thank you so much for that update. We're very glad you were able to be with us today. That concludes our speakers. We now have a few minutes for questions. Please feel free to put your questions in the Q&A box at the bottom of your screen. And here's our first question. Of the data you have, how do you ensure it is reliable and authentic? In India, we managed to gather some data from news reports mostly. Very few states updated info on their websites. And this is a problem that's been alluded to earlier in this discussion. So I would ask Jada and Trina to take the first attempt at responding to this question.
Thank you, David. I'll be very brief. And just to mention, there's been a lot of very interesting questions. So I just dropped my email in the chat. And if anyone wants more specific information or data, please feel free to email me. With regards to reliability and authenticity, that's actually a very interesting point. As I said, there were 6 countries. They are mentioned in the report, but they are Argentina, Canada, Chile, Colombia, Italy, and Thailand, whose governments provide a sort of updated and disaggregated official databases. So we started from there. Then we had some private interactions, let's say, with health or prison authorities. So we send those freedom of information sort of requests, and we got some information back. We also accessed some through Europris or similar databases, reports developed by prison authorities themselves. And so when we had that kind of information, we kind of trusted authorities that the information provided was reliable. When we got, and sometimes we got different information also in official, so we had official figures in different sources, which was different. Then we followed sort of the lowest, and we reported the lowest number. For independent reports, we went with attempts to triangulate the information. So we talked to contacts in different countries to try and understand the reliability of the sources. And in any case where we couldn't confirm the figure, we reported the lowest figure. Again, just to reiterate, the figures that we give are not the comprehensive one, but the minimum confirmed. In a lot of cases, there are, for example, figures for only one prison in the country, because that was really the only one that we could confirm. I hope that makes sense, but I'm happy to give more details if necessary. Trina, I don't know if you have anything to add on this.
No, just to add around the sort of national data collection can be really tricky. I mean, that goes for any sort of data across prison systems and also relates to vaccination figures. And that can also be, you know, how the systems are set up and whether the information is collected. So in some cases, the prison authorities or health authorities themselves don't have that information. So it's not always just a question of transparency, but also the actual practical collection of the data. In some places, there's you know, different governing authorities for pretrial detention and convicted or sentenced persons. So this kind of complicates the national figures. So yeah, just otherwise, Jada has, I think, been pretty comprehensive in that.
Thanks to you both. One of our participants wanted Raed to expand on his point that in countries where the Minister of Health had more authority over the prisons, the response was better. Raed, are you able to say more about that?
Yes, actually, we work on it for a very long time. There is a very nice nice note or book done by the UNODC and WHO Europe about the best practice related Minister of Health and Minister of Interior and Minister of Justice. Actually, the Minister of Health, when he is in charge, he's really following the stuff. They are more following all the latest information about health system, about education, about COVID-19. They attend meetings. But sometimes the staff who are under Minister of Interior, they are there for the last 10 years. They never attended any course. They are not following any ideas, one thing. Second thing is that they follow medical ethics more practically than the one who's outside or inside the prison. You know, there is a Ministry of Health who's following them. They are treating the patient like it was in the clinic, so etc. And it was a big debate about it, and that's the reason why you could see now in Europe, let's say Italy has changed to Minister of Health, France changed to the Minister of Health. In Europe, they are changing all from Minister of Interior or Minister of Justice between two practice into the Minister of Health, because it is the instrument. Health is part of public health, and Minister of Health is in charge of health of the country, including the detainees. But trying to make it dichotomy and to divide it like happening in various countries is that it is not necessary the Minister of Health is aware about what's happening inside the place of detention. TB is an example, HIV is an example, ill-treatment and torture is an example. I have a lot of examples. But actually the one who asked the question, I already sent him the book, which is online on Google. Thank you.
Excellent, thank you. Here's another question. What recommendations do you have to reduce the impact of lockdowns within prisons when rehabilitation, exercise, and education programs are limited to ensure social distancing? I think any of our panelists could address this, so please go ahead.
I can start and maybe others will come in as well. Yeah, this is a really key issue that we've highlighted, particularly through our Global Prison Trends report, which was published in May this year. And that's an ongoing program which monitors a lot of these key issues. And it really highlighted the fact of not only the impact of COVID directly in prisons, but also the knock-on effect then of the COVID response. And the very wide-ranging impact that has on health, you know, not just in relation to COVID-related healthcare, but non-COVID-related healthcare and all of the delays, and then also on mental health, particularly in response to, you know, the really increased isolation and restrictions on movement, which has been really ongoing for such a long time. And a lot of what we saw was, even as the community came out of a wave, and maybe restrictions were eased in the community, a lot of times that wasn't reflected within the prisons. A lot of this came down to maybe staffing issues, where prison staff numbers were really under-resourced, and also dealing with the impact of COVID among the staff team, and just total inability to therefore kind of reinstate the regimes from before the pandemic. So we've seen some sort of advocacy at national level, which has been effective, where there's a close collaboration maybe between, for example, community organizations who are maybe able to offer some sort of online or remote activities. But I think in a lot of cases, it really speaks to the issue we're discussing today, where also in the community, it has been high levels of vaccination in some countries that have allowed more easing of restrictions and more free movement. So I think also this will be a key factor in prison responses as well, where we can, ensure greater protection and therefore allow more movement and programs and less restrictive regimes.
Thank you, Trina. Yeah.
Yeah, if I can add just very briefly to what Trina said and to the recommendations in the report. Since the outbreak of the pandemic, we've repeated again and again, COVID must not be sort of a blip in the system. It must be really a wake-up call to reevaluate criminal justice policies and to really rethink who should be in prison in the first place. Of course, we need to vaccinate people. We need to decongest prisons where possible. We need to connect prisons and communities better. But we need to look very closely at who's in prison right now, why these people are in prison, and whether there are opportunities to maybe avoid them entering the criminal justice system in the first place. As I was saying before, 1 in 5 people today is detained for a drug offense. There are people detained for non-payment of fines, of debt, for petty offenses. And this really is one of the again, it's not just a human rights issue, it's not a drug policy issue, but really is a public health issue. And decongestion could be a way to, first avoid people entering prison and also allow people who are in prison to live a more, dignified and humane life while in detention.
Thanks very much to you both. We've been talking about vaccination for prisoners and prison staff. One participant asks, what do you find on vaccination protocols for families and those that access the prison population beyond staff? And the questioner points out, as has already been discussed, that in many countries, prisoners rely on visits from their families, not only for emotional support, but for food and medicine and other necessities of life. So what do we know about vaccination requirements for family visits and other kinds of visits to the prison, maybe legal visits as well?
I'll maybe start briefly, and then I swear I won't turn my mic on anymore. There's very little we know, and actually this is an area where more research is needed and would be welcome. That said, there were some instances, for example, in Malaysia, where it was reported that single prisons, and this is the other thing with vaccination, a lot of times the decision was not made at the national level, not even at the local level, but really at the prison level. And in some cases, the decision was made by prison administrations to vaccinate prison staff and their families. That was not the case for people detained in prisons. We also saw families becoming advocates for vaccination in prison. That was the case of the Philippines, where a group was, we have case studies in the report. A group was formed of families of prisoners, sort of calling for prioritization. Unfortunately, what we mostly saw, but again, we know very little, was that families was really not thought of as sort of part of the prison community, and so not targeted specifically. We also had the case raised by advocates in Saudi Arabia, the European Saudi Organization for Human Rights, which noted that in a lot, that goes back to what Ride was saying, in a lot of cases, prisoners got vaccinated. So people detained were vaccinated, people working in prison were vaccinated, families reported their vaccination, but still prison authorities did not restart visits in prison. So COVID really was an excuse to sort of block the connection between the community and the prison. But that was basically everything we found through this first scan. I don't know if anyone else has more information.
Further responses on this point?
In some places, I'm sorry to come, but in some places, exactly what Giada has said. But what we did a kind of a protection with glasses, masks, and hygiene. So even if the authority is saying family, difficult transmitting, we try to do it like in some cases in some TB program in which the ICRC was having, that it's a kind of a protection with glasses and etc. And they can see each other and they can, at least from far away, talk to each other with masks. And actually, we were sure that when they come into the room, there is hygiene related hands and they don't touch anything and etc. And then they see the family from a distance with a glass and it works. And then the authority realized that it works. And then they allow them to come in with a very, very careful hygiene related issue. But it was a proposal because actually, if we didn't propose it, I don't think they will make the effort. So I think sometimes it's an excuse, but sometimes it really, they need a solutions. And so it depends where we are. Sorry.
Thank you very much for those responses. That concludes the question and answer period. And now for closing remarks, we're very fortunate to have with us Naomi Berkshine, the Executive Director of Harm Reduction International.
Thank you so much, David. And to all our incredible speakers this afternoon, couldn't imagine a more relevant way to spend a lunch hour during December 21 in the context of what we're all grappling with. Please, David, let me particularly call you out for your masterful moderating, 90 minutes and closing on time. Zoom is finally paying off for us. And if I could just commend Sharon Olenahan and Giada Girelli for the incredible work they've done on this report. I'm going to say just 3 things, so we will close on time. The findings of this report emphasize the ongoing failure of governments to promote health in prisons. Punitive policies, including drug policy, are driving ever higher levels of incarceration. But once incarcerated, millions of people become an afterthought, and that is not acceptable. It certainly isn't going to result in safer societies, healthier societies. It doesn't result in the protection of human rights. As our speakers emphasized, people in prison are entitled to the same level of healthcare as in the community. This human rights standard actually has really important benefits for both community and prison health. HRI sought out this research because approximately 2.5 million of the 11 million people in prison globally are there because they're convicted for drug offenses. A big part of the disastrous state of prisons today is related to drug policy. And in this context, we're so pleased to partner with PRI to take this evidence-based, human rights-focused, informed review of how we're faring with this critical issue of COVID protection and vaccines. We'll close by drawing your attention to 3 key points from the report recommendations. People detained in prison should be explicitly included as a high priority in national COVID-19 vaccination plans and vaccination rollout on the basis of their increased vulnerability. Authorities must collect, make public, and regularly update data on COVID-19 vaccinations amongst people in prison and prison staff. And a health and human rights-based approach to prisons involves using imprisonment only as a last resort, taking measures to reduce overcrowding, such as release schemes, and ensuring healthcare is evidence-based, human rights-based, and gender responsive. Thank you all very much. Please catch our report online. Have a good afternoon.
Thank you so much, Naomi. Thank you again to Harm Reduction International and Penal Reform International for organizing this event. Thank you to all of our distinguished speakers, and thanks to all of you for joining us today.
Thank you.